Good afternoon, everyone. My topic is also about the left main coronary intervention. Uh, we will discuss the technical approaches for the challenge lesion. As we know, the left main has unique anatomic features which should be taken into account during our clinical practice because it has the large and high variable diameter and the disease always is diffused and may extend it into the two branches and the left circumflex branch is often relevant because it supplies more than 10% of myocardium in most cases, and it's very important for the decision of the intervention for the left main. When we, according to the now practice, clinical practice, left main revascularization is indicated for angiographic stenosis is more than 15% and documentation of myocardial ischemia. Of course, left main disease is sometimes difficult to access with coronary angiography. So, adjunctive device may help us to understand the severity of left main disease. For example, if the IVAS and alfalfa all the device could help us to detect the function of the stenosis. If the minimal lumen area more than 6 square millimeters, and if the FFR is more than 0.8, which are acceptable criteria for different left main revascularization. Interpreting the FFR in the presence of significant downstream branch lesions is very complicated. So, physiology is often favored for assessment of simple, isolated, or distal left main bifurcation stenosis. The first step is wiring for the setting up for left main stenting. It is advisable to wire both distal branches before balloon dilation unless rotor ablation is planted. A placement of a wire in the second branch is very important, which could increase the PCI safety by facilitating side branch access, helping to maintain side branch partition, serving as a marker in case of branch occlusion, or to access the side branch by advancing a small balloon. In the procedure, if the Y fails, the first step is to modify the Y tip shape. Of course, soft tip Y with increased torque ability will be a reasonable secondary option. In case of percent branch Y failure, some valuable options such as the single or dual lumen microcatheter will be helpful. For this case, we can see the very significantly stenosis of the distal left main with a large angle at the left circumflex ostium. So it is very difficult to enter the Y use the common method. Then we try use a tapered low tape load polymer jacket guide Y with the support of microcatheter. We can see it is easily pulled put to the distal segment of the left circumflex. Of course, the tip of the Y should be with a large angle curve. For some case, the reverse Y technique with dual lumen microcatheter is necessary. As reported by a previous professor, lesion preparation is very important for left main stenting. The lesion preparation technique depends on the vessel anatomy. If we found the noticed fibrocalcific plaques, root ablation or IVL, and NC or skull balloon are usually selected before stent implantation. As we know, routine side branch predilation is not recommended. However, in the presence of side branch with significant stenosis or a very calcified lesion or difficult side branch access, predilation may be an acceptable option. This is a very challenging case, just from the angiography, we can find the heavy calcification lesion in the bifurcation of left main, and with significant stenosis at both the LAD ostium and left circumflex ostium. And the CTA showed the location of the bifurcation with heavy calcification. So for this case, root ablation is very important because the imaging catheter cannot cross the lesion. Firstly, we choose a 1.5 millimeter bore to perform root ablation for the left circumflex. Then, with a larger, bigger bore to root ablation left anterior LAD. So after root ablation, we found use IVAS imaging. We found there are also still circumference calcification. Next, we performed IVL with 3.5 millimeter balloon. This is the final result with its excellent after 2 stent implantation. Another question is for the stent size for select in the left main stenting. It is a common situation when the left main coverage is achieved with the same stent. So the stent size is selected according to the distal vessel size, and then appropriate stent expansion is recommended according to the port technique. A knowledge of different DS platform characteristic is pivotal during stenting procedures, and the restant of the stent to the longitudinal compression also should be taken into consideration. For example, the sinus radius root and the synergy stent will get a high diameter, stent diameter after port. For the stenting technique selection, when the left main stent plaque involves one branch only, the provisional strategy may be recommended. For example, the side branch lesion is less than 17% stenosis, and the length is no more than 10 millimeter, or the minimum lumen area is bigger than 4 square millimeters, or the plaque burden is less than 15%. For the provisional strategy, port is recommended to be performed just as described in the previously speak and the last topic. Whether it's necessary to perform kissing balloon inflation after port is currently unknown, but in the registry study, we can find about 8% procedures complete the kissing balloon inflation. In the absence of a suboptimal signed branch result, the need to clear stent stress from signed branch ostium continue to be debated. The floating stress across the ostium may support the development of osteo multiple holes restenosis. For this patient, we can find a filling defect with a round shape in the ostium of circumflex, and we performed IVAS imaging, and the results showed new intimal growth over the stent stress, and splinted the circumflex ostium into orifices, such as when the signed branch are compromised after provisional stenting, the TTAP or culotte techniques are adequate for bailout signed branch stenting. For the double stenting technique, it's suitable for the both vessels are significantly diseased, which seem to be better approached by the double stent technique. And among different double stenting techniques, Dickey crush has become increasingly popular since it could significantly reduce the fine kissing inflation failure rate. For the double stent technique, after 2 stents implantation, a port is first performed, and then the KBI should be performed, and the next report is advised. But we should note that the position of the port and the report is different. It's a port performed to the proximal main vessel, but the final port, also we call the report, with slightly more proximal position. Next step is very important. We can use intracoronary imaging and functional assessment to optimize the left main PCI. Both IVAS and OCT can identify important intra-procedure stent features, such as the stent and expansion structure malposition or edge dissections. Based on the finding, we can perform further intervention to optimize the final result. For standard criteria, the minimal lumen area after 2 stenting is respectively 5, 6, 7, 8 square millimeters. But recently, the 6, 7, 10 square millimeters is recommended. The most common complication in the left main procedure, PCI procedure, is longitudinal stent deformation. It's a special risk due to the interference with the stent and the guiding catheter. For this patient, we can see the stent deformation caused by the deep engagement of the guiding catheter, and after port, we can see the deformation is corrected. This is another case of stent deformation. The patient represented with chest pain 6 weeks after his first PCI. From the angiography result, we found there is a significant stenosis of the ostium of LAD, and intravascular imaging use MRs. We can see that from distal to proximal, we can find the stent thrombosis, multiple layers of stent, and dissection without stent stress. This is a classic stent deformation. There are several methods to avoid the catheter engagement and to avoid the stent deformation by to prevent the catheter engagement. One method is floating wire technique, which can prevent the engagement of the catheter. Another technique is balloon ankle technique. For this situation, if we withdraw the gelled wire, we can inflate a balloon in the distal segment of the stent. It will be sufficiently to prevent the engagement of the catheter and to avoid the stent deformation. Of course, the PCI team may play a pivotal role in successful managing patients with left main disease, especially when the patients experience completed causes. Accordingly, it is important that hemodynamic support device are immediately available and can be inserted and activated quickly. Thank you very much.